Podcast is now starting. All attendees are in listen-only mode.
Well, hello, everyone. This is Feliz Barkan, the president-elect of the American Society of Cytopathology. Thanks for tuning in to our weekly educational session. Today, our guest is Dr. Sara Monaco, and we're really excited because we're going to be learning about lymph node pathology, lymphomas, and beyond. But before I introduce her, let me just go over her bio so that you get to know her in person. She is actually a wonderful person. She grew up in New York and attended Cornell University, and then went on to school at Columbia University College of Physicians and Surgeons. She stayed there as a resident for anatomic and clinical pathology, then completed her training, including the Cytopathology Fellowship at University of Pittsburgh Medical Center. She's currently there now. She's an associate professor at the Department of Pathology at UPMC, and she has a special interest in cytopathology. She holds the title, the Cytopathology Fellowship Program Director, and she's also the director of the fine needle aspiration biopsy services at the UPMC Children's Hospital in Pittsburgh, as well as the UPMC Shadyside Hospital. She's been there actually for 14 years, but come next month, she'll be moving to Geisinger Medical Center in Danville as the system director of cytopathology. Now, she has been a very active member of the ASC over a number of years, but she's also one of our board members. She's on the executive board of the ASC, and she's also the Cytopathology Fellowship Program Director Committee, which is our liaison between the ASC and also deals with all the educational issues that the cytopathology community is facing. She is married and she has 3 wonderful kids, and in her spare time, she gets to enjoy the time with all of her family. So without further ado, I give you Dr. Monaco and lymph node cytopathology.
Thank you, Dr. Barkan. And I wanted to really thank the ASC for holding these sessions during these challenging times. I also wanted to sort of welcome everyone who's virtually present today, whether you're in the US or outside the US. And I hope this finds everyone safe and healthy. My topic today is going to be on lymph node cytopathology. And see. And just to reiterate and sort of thank everyone for their service and everything that they're doing during these challenging times. These are signs outside of our hospital sort of thanking all of the healthcare workers in Pittsburgh. So my first polling question is just to get a feel for who the audience is today. So I'll open polling.
Okay, let's see. All right, here we have it. Who is attending the webinar today? Please choose the category that best describes you or the majority of the people at your site. We're assuming that you're by yourself, but maybe you have masks on and you're sitting somewhere there with a group. So select one of the following: cytotechnologist, resident, cytopathology fellow, pathology fellow other than cytopathology fellow, and cytopathologist.
Okay.
I don't know if you could see it.
Oh, yeah. Okay. So it looks like the majority of people are cytotechnologists, followed by cytopathologists, and then 21% are residents, and smaller percent are fellows. Well, I welcome all of you today. Okay, these are the learning objectives, and I'll just make a point to mention that in your sidebar of the webinar today, there is a handout, a PDF of a handout that you're welcome to download if you want. And the learning objectives are there. So in brief, for the outline today, we're going to start by talking about approaches to how we evaluate lymphoid specimens with small biopsies and how we look at these cytologically, whether it's on aspirates or on touch preps. We'll talk about some specimen handling pearls of wisdom, and then we'll move on to sort of a case-based approach and show some common and uncommon lesions. And then I thought it would be fun today to try to do a virtual cytology game if time permits, and with some concluding statements. So in brief, most of us know that the use of lymph node small biopsies serves a variety of purposes. And in our practice in Pittsburgh, the most common organ that we sample with FNA is actually the lymph node. So it's quite a common specimen, and you can see a variety of different things. And a lot of times when a patient has lymphadenopathy or a mass lesion, the main concern is it benign or malignant? Could it be infection or something that wouldn't need surgery? Can we diagnose, subtype, and stage these patients? And we know from Dr. Booth's lecture a couple of weeks ago on EBUS FNA, a lot of times when we're doing EBUS of lymph nodes, we're serving a really vital purpose in doing minimally invasive approaches to sort of stage lung cancer patients. We also look for sort of secondary involvement or recurrent or residual disease once a patient has a known malignancy. And in terms of lymphoid processes, a lot of times we're looking for transformation in patients who do have sort of a long-standing lymphoproliferative disorder, and then to also assess for prognostic and predictive markers in lymphoid lesions and also in other types of tumors that we see. And really, the small biopsies and FNA in particular has been very helpful, particularly in pulling out benign or infectious etiologies that can relieve the anxiety for the patient and really avoid surgery for patients that aren't good surgical candidates or for disease or processes that don't require surgery for treatment. And I will say, in recent years, there's a lot of emphasis on prognostic or predictive biomarkers in solid malignancies, but we also see this in lymphoproliferative disorders. Just to give you two relatively recent examples of patients who had large cell lymphomas. And in our institution, sometimes these patients are treated with anti-CD20 agents like rituximab. And sometimes when patients are failing therapy and not doing well, we'll see a loss of CD20 antigen expression on their tumor cells, which kind of explains why they're not responding to the anti-CD20 agents. And likewise, we have a pretty busy immunotherapy protocol now for lymphoproliferative disorders and lymphomas. And for those patients getting CAR T therapy that targets CD19, if you look here on this flow interpretation, we're seeing B cell populations that may lack markers that we typically associate with B cell malignancies like CD19 because they're being targeted by some of these therapies. And so it's important, of course, to know the clinical history of the patient and their treatment history in terms of understanding the immunophenotype of their tumor these days, as it may explain why they're not responding to treatment anymore and what can be done to sort of change that. So just to sort of review some of the specimen types that we see for lymphoid lesions or lymph nodes in particular, we see a variety of cases where just FNA only, and a lot of those FNA only cases come from our pathologist performed FNA service, which can be either by palpation or with pathologist performed ultrasound guided FNA. And we really don't do core biopsies in our pathologist run clinic. So those would be FNA only. In addition, our EBUS and EUS guided biopsies are typically FNA or sometimes the Acquire fine needle biopsy, little ProCore or bigger sort of FNA needles. And then there's the radiologist performed biopsies that include FNA only, FNA with concurrent core needle biopsies, and a series of core needle biopsies only. So this is kind of a variety of different specimen types that we see for lymphoid lesions. In Pittsburgh, in general, when we're thinking about a lymph node and concern for a lymphoproliferative process, we typically are doing FNA with concurrent core needle biopsy for most of these cases. So just a typical day in my life in Pittsburgh is sort of getting a FNA of a lymph node, and we do rapid on-site evaluation for these cases. And particularly during COVID, we've seen a lot of decrease in a lot of our specimen types, but for some reason, our small biopsy service, and particularly the interventional radiology guided biopsies, has really sort of not seen as much of a decrease. So we've been pretty busy with rapid on-site evaluation. So once we look at these FNAs from lymph nodes, we then decide, does a core needle biopsy need to be performed, or can we reach a diagnosis? And typically, if we can put it into sort of a reactive population, infectious etiology, or metastatic carcinoma, and there's sufficient cellularity and it meets what they were clinically thinking, sometimes those cases will not get a core needle biopsy and the procedure will end, and we'll get dedicated passes from the FNA for cell block or ancillary studies. Then there's a variety of scenarios where we will convert to a core needle biopsy, and those scenarios include when the FNA is sort of scant and limited, if there's a concern for classic Hodgkin lymphoma, or basically almost any lymphoproliferative disorder, particularly for grading or for primary diagnosis. A lot of times we will do a concurrent core needle biopsy at the time of the procedure. And I can't emphasize enough, obviously, when you're at the time of rapid on-site evaluation, morphology is really key in order to appropriately triage these specimens. So this is a side-by-side composite on the left of a Ewing sarcoma, and you can see that sort of tigroid background from the glycogen in the background, and a little bit more cohesion than you would see on the right-hand side, which is a lymphoma that shows more discohesion, the presence of lymphoglandular bodies, and a more discohesive population of cells. And really, ideally, having a really well-prepared smear or touch prep is really critical for making this distinction from lymphoma or something else and adequately triaging that specimen. So this is an example of when the preparation is sort of not ideal at the time of on-site evaluation. So these are two touch preps, and there's really extensive crush artifact that when I look at the top two diff-quick images, it's really hard for me to distinguish the non-Hodgkin lymphoma on the left from the small cell neuroendocrine carcinoma on the right. I think if you look a little bit closely in the small cell neuroendocrine carcinoma, you see a bit more of nuclear debris fragments of apoptotic cells, which you typically don't see in most non-Hodgkin lymphomas. And if you look closely, perhaps there's a hint of lymphoglandular bodies, but it's really pretty tough with all this crush artifact to tell exactly what's going on. However, when you do get really nicely prepared smears or touch preps, like in this scenario, you can more adequately be more definitive in what you're thinking and then adequately triage those cases. So when I look here, now it's easier to sort of appreciate that cohesion of the neuroendocrine carcinoma on the right and the more discohesion of the lymphoma on the left, sorry. So this brings up sort of a point about slide preparation. And I think a lot of times we're experts in smear preparation, particularly our cytotechs and our pathologists on site. And I think that's one of the things we sort of emphasize to our trainees is trying to make really nice aspirate smears and sort of avoiding sort of crushing the cells and doing sort of too traumatic smears. But I will say touch preps, there's also sort of an art to making a great touch prep as well. And we've seen some vigorous touch preps where the core is kind of rolled all over the slide. And there tends to be a lot of cellular loss in those sort of scenarios. And so we've tried to do as little tissue manipulation as possible. And I will say some of the sort of pearls of wisdom in terms of creating a touch prep that isn't too manipulated is to sort of drag that core piece towards the short edge of the slide, not the long edge of the slide. And in addition, if you can sort of pick up that core and not drag it as much as possible, we've had some luck pulling the cores off with sterile needles and then preserving the needle so that it can be used again. And that's sort of a cost saving measure as well. And that core needle can then be used again to get another core. And then we've also used the sterile needle cap cover to sort of tease that core out of the core biopsy needle and then lightly touch it to get a touch imprint on that slide. So as I mentioned, this is sort of the way we work up different types of specimens. So in the majority of our lymphoma cases or cases suspicious for a lymphoproliferative disorder, we'll do an FNA with concurrent core needle biopsy. We'll usually look at the FNA first, and if the FNA looks worrisome for lymphoproliferative disorder, the aspirates will then go into RPMI and sent off to HemePath for the flow cytometry lab. We also will frequently do unstained smears if we want to save material for potential FISH studies. And then we typically use the core needle biopsies for formalin-fixed paraffin-embedded blocks that then can be used for immunostains. In the scenarios where we have core needle biopsy alone, we then would put a core in for flow cytometry. And in FNA alone, we would also submit some stuff for a cell block. But in the scenario where we're doing FNA with concurrent core needle biopsy, we usually do not do a cell block and simply submit the aspirate needle rinses for RPMI and for flow cytometry. So the question comes up, now that we're doing a lot of FNA with concurrent core needle biopsy, like why even do the FNA? So there's a couple of reasons why we do it. One, it's safe and relatively quick. It can really help to determine if the process is lymphoid. And sometimes that alone is telling them something that they need to know. In addition, you tend to get really good morphology. Sometimes I feel like the touch preps and core needle biopsies lend themselves to a little bit of a thicker and more crushed specimen to evaluate than a good aspirate smear. And then the aspirates are really ideal for flow cytometry. And this is a great paper that was published in 2015 that basically showed that FNA aspirates were superior to core needle biopsies for flow cytometry. They showed better viability and more cells for analysis. And so this is sort of one of the reasons why we end up sending our aspirates for flow opposed to our core needle biopsies. And I actually had the experience of watching our flow cytometry lab process core needle biopsies. And our lab does a lot of sort of mechanical digestion of tissue so that the cores of tissue are put in a petri dish with RPMI, and then a tweezer is used to sort of squeeze the cells out of the core. And sometimes a sterile needle is used to manipulate it. But there's a lot of tissue manipulation that goes on, and sometimes the cells just can't survive. And so you can really get low viability specimens and maybe non-diagnostic flow cytometry with cores, opposed to a good FNA aspirate that really doesn't need any manipulation by the flow lab. And 5, obviously, to maximize diagnostic yield of the procedure. If you have an FNA and a core needle biopsy, you really have 2 separate procedures, 2 different specimens to get sufficient material for studies, whether it's flow or immunostains. So then the next question comes, well, why do the core needle biopsy? And we've seen in our practice that there's really been a push to do more of the FNAs with core needle biopsy, particularly for lymphomas. And a lot of this is clinician oncologist driven, because a lot of the NCCN guidelines basically say that if you're going to do a small biopsy and not excise the lymph node, that really a combination of core and FNA in conjunction with ancillary studies is more ideal than just doing one or the other. And so we really have seen a lot of emphasis on both the FNA and core needle biopsy, and I think both have their advantages. In general, in terms of accuracy, small biopsies are not perfect for the diagnosis of lymphoma. In general, it's a good rule of thumb to think about 75% are usually adequately classified for treatment purposes. And there's 25% or so that may need to go on to an excisional biopsy. We do know from some studies that the more tissue you get, sort of the longer the tissue or the more volume, the greater the chance of having diagnostic yield and accuracy. And we also know in a lot of meta-analyses looking at lymphoma studies that some lymphomas are just particularly difficult on small biopsies. And that includes grading of follicular lymphomas, marginal zone lymphomas, T-cell lymphomas, and classic Hodgkin lymphomas. I put this slide up here just to reiterate the fact that you always have to be thinking of lymphoid lesions. Even when they tell you it's a kidney mass and not a lymph node, you have to be thinking of lymphoma. So this was actually a renal mass, worrisome form of malignancy, particularly a renal cell carcinoma, and actually was a large B-cell lymphoma infiltrating the kidney. And so obviously proving that this is lymphoid and proving that it's lymphoma is particularly helpful here to avoid a nephrectomy and allow the patient to go on to treatment. And if you look closely here, a lot of times when these specimens or touch preps are crushed, if you look closely at sort of a well-preserved area that's not as crushed, you could see signs of lymphoglandular bodies as a clue that you're dealing with a lymphoid process. And here you can see the immunophenotype supporting a CD20 positive B-cell population sort of infiltrating in and around the glomeruli and the renal tissue. So in general, most of us know that the morphology of lymphoid cells tend to be sort of discohesive cells with lymphoglandular bodies. Sometimes in reactive processes and in high-grade lymphomas, you may see tingible body macrophages, so that can be a helpful thing to look for. And really, when you look at these specimens, you want to rule out metastatic carcinoma or clusters of granulomas, and then look at the lymphoid cells and ask yourself, how homogeneous are they, or are they polymorphous, and what are the cell types present? So a lot of times people ask, like, well, how do you know when to triage for flow cytometry? And typically we use this string of pearl test, and basically it's a test for monotony. And so if you can connect cells of similar chromatin character and similar size across a 40x field, usually that's sort of a test that it's too homogeneous and you should be thinking about a lymphoproliferative disorder. So this is sort of that string of pearl test for monotony and sort of making yourself think of a lymphoproliferative process that would triage for flow cytometry. This is your typical sort of benign reactive scenario, and a lot of times this requires sort of clinical correlation to make sure that it really does look like a benign or reactive process. But you can see these conspicuous tingible body macrophages in the center. And overall, opposed to the previous image, there's this sense of polymorphism, that there's a polymorphous population of small cells, intermediate sized cells, and it's really hard to connect cells of similar size and chromatin characteristics across a 40x field. So once you do have sort of a monotonous lymphoid population that you're concerned about, you really should then sort of put it into a small, intermediate, or large cell population to sort of render a differential diagnosis. And usually the index of comparison is either a histiocytic nucleus or 2 red blood cells. And we know that there's a whole variety of different things in the differential of small cell populations and large cell populations. I will say I typically try to remember the intermediate size category, just to remember myself that these can basically be seen as small or large sometimes, and those can be sort of challenging. And those 3 most important sort of intermediate sized ones to think about would be lymphoblastic, Burkitt, and mantle cell lymphoma. So I thought we would just sort of put this to use and sort of look at the morphology of this lymph node. I think this case kind of shows some really nice morphology that would make you concerned for a lymphoproliferative process. When I look at this case, I can see in the red, you see sort of a mature lymphocyte with its condensed chromatin and really no appreciable cytoplasm, whereas the cell in the yellow box has a little bit of more cytoplasm that's appreciated. It has sort of nuclear grooves and irregularities, and it has this sort of lighter purple, more immature appearing nuclear chromatin. And if you look in the orange box, you can see 2 red cells juxtaposed to some of these abnormal cells, and you can see that really these abnormal lymphocytes are smaller than the size of those 2 red blood cells, sort of indicating an abnormal, small, cleaved lymphoid population that would be concerning for a follicular lymphoma. And this case in particular shows really nice lymphoglandular bodies as well, confirming that it truly is a lymphoid process. Concurrent core needle biopsy does give you architectural features that can be helpful and can be really difficult to appreciate on a cell block. And so here you can see these nice sort of germinal centers highlighted with the CD21 meshwork and the BCL2 positivity. Okay, so with that, we're gonna move to case 1. This is a lymphoid aspirate in a 6-year-old boy with lymphadenopathy, and we will open polling.
Okay, here's the poll. What is the most likely diagnosis in this case? Negative for malignant cells, benign reactive lymph node. Negative for malignant cells, granulomatous lymphadenitis. Negative for malignant cells, Rosai-Dorfman disease. Suspicious for malignant cells, round blue cell tumor. Positive for malignant cells, non-Hodgkin lymphoma. 2 more seconds, and then Joanne could show. All right, looks like majority of them say negative for malignant cells, benign reactive lymph node.
Okay, great. So I think when people choose a benign reactive lymph node, I was showing something I was hoping you would think was that. And you can see lots of small lymphocytes. And I think what draws your eye are the cells in the center that seem quite bigger and sort of reminiscent of tingible body macrophages. However, unlike apoptotic debris, it actually looks like these are lymphocytes sort of passing through macrophages. And sometimes these macrophages have this very water clear cytoplasm, and it's almost hard to appreciate the nucleus, which is kind of vesiculated and almost in the background from all of these sort of bag of lymphocyte nuclei sitting on top of it. And there you can see sort of the histiocytic nucleus sort of peeking through. So unlike tingible body macrophages, these actually have lymphocytes wandering through. And this is an example of peripolesis, which we see in Rosai-Dorfman disease in young children. What I didn't show you was the ultrasound, which really showed pronounced lymphadenopathy for this young 6-year-old. And when you see pronounced lymphadenopathy in a kid this age, this is something you should think about. As I mentioned before, you'll see these macrophages at low power. They're very easy to identify. And at high power, you'll notice that they are actually lymphocytes just passing through and not apoptotic debris. This is actually an H&E stain touch prep, and you can see here there's sort of almost like a clearing or a vacuole around the cells passing through. So Rosai-Dorfman disease is also known as sinus histiocytosis with massive lymphadenopathy, and usually causes sort of massive painless lymphadenopathy that's bilateral in young patients. It tends to be self-limited. We have seen some extensive cases in Pittsburgh where the kids start to have the lymphadenopathy sort of compressing on adjacent structures, and those patients have responded to systemic steroids. And really the key is identifying peripoiesis opposed to tingible body macrophages, and these will be S100 positive and CD1A negative. So it brings up this idea of sort of large cells, and not all large cells are tingible body macrophages. So here's sort of 4 things around a tingible body macrophage, just to show you different entities that may look similar. So in the upper left is an example of histoplasmosis, where you can actually see the fungal elements within the cytoplasm of the macrophage. Extramedullary hematopoiesis, where you can see megakaryocytes with this sort of lobulated, multilobulated megakaryocyte nucleus. And then sometimes we'll see red cells passing through macrophages in erythrophagocytosis, and we've seen that in hemophagocytic syndromes in addition to viral-associated erythrophagocytosis in kids. So the take-home point here is that you could see tingible body macrophages in reactive populations in the lymph node, but you also want to think about high-grade lymphomas where you can see them, and also low-grade lymphomas. And this is a particular case of a marginal zone lymphoma. And I will tell you, if you have a patient who's an adult with pretty pronounced lymphadenopathy and you see tingible body macrophages and you're not certain, it is a good idea to send for flow to sort of rule out some of these low-grade B-cell lymphomas. Okay, case 2. This was actually an 18-year-old girl who was home from college, and she was particularly tired and had lymphadenopathy, and so mom and dad thought she had mono. And so this is the image, and I'll let Gulise and Joanne open polling.
Okay, here's case 2. What is the most likely diagnosis? Negative for malignant cells, benign reactive lymph node. Negative for malignant cells, Rosai-Dorfman disease. Suspicious for malignant cells, Hodgkin lymphoma. Positive for neoplasm, Langerhans cell histiocytosis. And positive for malignant cells, non-Hodgkin lymphoma. Couple of seconds, and then we'll let Joanne show the poll results.
Okay, great. So the majority of people, it looks like, chose Langerhans cell histiocytosis, which is the diagnosis, and a close minority thought it was suspicious for Hodgkin lymphoma, which is what I was thinking people would consider in the differential diagnosis. And so if you look at this image, what strikes you is sort of these ill-defined clusters of large to intermediate cells. Let me see, do I have to share my screen?
There we go. You have it now.
Okay. So I think what catches your eye is some of these loosely cohesive sort of intermediate to large cells that have a lot of this sort of syncytial cytoplasm. And really, it doesn't look like they're lymphoid cells. I think most people would favor maybe that they're histiocytic in origin. However, in the background, you do see a lot of eosinophils. And I think when we see eosinophils, we always think about maybe classic Hodgkin lymphoma, but you should think about sort of eosinophilic granuloma, which is what Langerhans cell histiocytosis used to be referred to. And you can see why here this truly does look sort of granulomatous with a lot of eosinophilic sort of microabscesses around. And when you do look at the histiocytic nuclei, they do look quite twisted and like there are some irregularities and indentations to them beyond what we would typically see for a multinucleated macrophage or benign histiocyte. So this is Langerhans cell histiocytosis. If you do a CD1A stain and a Langerhans stain, these histiocytic cells will be positive. This just shows you sort of a high power image showing how truly convoluted and almost clover leaf and indented a lot of these macrophage or histiocyte nuclei are. And on the pap stained image on the right, you get a real full feel for those grooves and sort of indentations in the nuclei. So I thought I would show this as a differential because I think a lot of times when we see Langerhans cell histiocytosis, we think of a histiocytic or granulomatous process. And I remember looking at this case and the trainee thought to me, oh, wow, it looks like grooved nuclei like of Langerhans. So this was actually non-necrotizing granulomas with the negative image of atypical mycobacteria. And you can see here when those atypical mycobacteria are sort of overlying the nucleus, sometimes people can think that looks like a groove or features of Langerhans cell histiocytosis. But in reality, it's just the organism, since the mycolic acid repels that diff-quick stain. It looks like a nice sort of negative image of a spaghetti-shaped structure. And if you do AFB staining on these, you usually get these sort of long, slender AFB positive organisms. Another thing that I always think looks sort of like Langerhans is normal dendritic cells that sort of have these sort of elongated cytoplasmic extensions and can look sort of more spindly and have less abundant cytoplasm. And in contrast to the Langerhans case, you really don't have eosinophils in the background, and you don't have that conspicuous indentation, grooves, and twisted nuclei that we saw. Okay, case 3. This is an older patient. So this is a 76-year-old man who presented to our hospital with extensive lymphadenopathy. And this is the lymph node FNA. And so I'll have Gulise open polling for this case.
All right, so what is the most likely diagnosis in this case? Negative for malignant cells, benign reactive lymph node. Negative for malignant cells, granulomatous lymphadenitis. Negative for malignant cells, features of infectious mono. Suspicious for malignant cells, suspicious round bull cell tumor. And positive for malignant cells, non-Hodgkin lymphoma. Let you think about that for a minute. And Joanne will close the poll.
Okay, it looks like we got an overwhelming majority here for positive for malignant cells, non-Hodgkin lymphoma, which is the correct diagnosis. I was trying to trick everybody because I thought sometimes these cells look like multinucleated or grooved cells. So I was trying to see if anyone would thought it could be sort of histiocytic cells, but it sounds like most of you recognize this as sort of an immature, intermediate to large population of lymphoid cells that appear abnormal. If you look closely, you will see that there is sort of this tingeable body macrophage in the center of the screen. And in addition, you'll see sort of numerous mitotic figures indicating it's likely sort of a very proliferative process. And in contrast to the histiocytic cells we saw in the past, you can sort of make these out to be lymphoid cells because a lot of them do have this deep blue cytoplasm, which is typically more a feature of lymphoid cells and wouldn't be as conspicuous in histiocytic type cells. And here you can see on the immunostains that it's CD20 positive, and as we saw with lots of mitotic figures, it is highly proliferative. Flow did confirm a lambda-restricted B cell population. So this is sort of one of those like aggressive B cell lymphomas with high-grade features and high proliferative index. And when we see these large cell lymphomas, we typically will send for FISH studies to analyze for BCL2, BCL6, and MYC gene rearrangements. And here you can see the BCL2 break-apart probe. And the way break-apart probes work is you have a red and a green signal to each sort of side of the gene of interest. And so when the BCL2 gene is rearranged and positive, you'll see those red and green signals as distinct signals. In a normal cell, the signals would be juxtaposed and give you almost a yellow signal. So here you can see the tumor cells here do have these split signals indicating that BCL2 is rearranged and would be positive. Likewise, for the MYC break apart, you can see here discrete red and green signals confirming that MYC is also rearranged. So now you've confirmed that you have a BCL2 and a MYC gene rearrangement. And the last one is BCL6. And you can see here on this break apart, the signals are juxtaposed, giving that yellow signal and would be negative or normal. So this is an example of a double hit lymphoma. These are typically aggressive lymphomas that we call B cell lymphomas that are mature, large B cell lymphomas. And usually these are either unclassified or put into a diffuse large B cell lymphoma category. Most cases are like this case, showing double hit with MYC and BCL2 rearrangements, but there are less common triple hit or double hit with BCL6. But the common feature is that MYC is rearranged with or without other chromosome abnormalities. And these can be tricky because they look sort of intermediate to large, sometimes blastoid, and you can see tingible body macrophages. And one of the distinct features to look for are these sort of larger cells with lobulated, sort of flower-like cloverleaf nuclei, almost like we saw with the Langerhans case, but much more of a lymphoid cytoplasm and smaller cells overall. These are some nice images from Dr. Wakely's paper in Cancer Cytopath, sort of reporting the cytopathology of double hit lymphomas. And you can see features similar to what we saw with our case, where you can see these sort of deep cloverleaf-like nuclei. And a lot of times these will have one or multiple sort of prominent nucleoli as well, in addition to mitotic figures. So a lot of times when we look at these double hit, triple hit lymphomas, sometimes you kind of ask yourself, is it really an intermediate lymphoma like a Burkitt lymphoma that can be high grade with starry sky appearance with tingible body macrophages? But usually Burkitt lymphomas are typically much more rounded without a lot of these clefts and lobulations. In addition, when we look at immunostains and other features, Burkitt tends to be younger patients. It's usually BCL2 negative. And usually if you see a MYC gene rearrangement, it's isolated by itself. It doesn't occur with BCL2 or BCL6 gene rearrangements. Whereas the large B-cell lymphomas that occur in adults are usually much more lobulated nuclei and have MYC with other rearrangements and are BCL2 positive. Now, another thing that we're doing a lot in addition to FISH testing is immunostains for MYC and BCL2 to look for double expressor lymphomas. So even if you weren't to do FISH studies on your lymphoma, but you had a large cell lymphoma that looked kind of high grade with a high proliferation index, looking for double expressor lymphomas are important because these do have a more aggressive course. Usually not as aggressive as double hit lymphomas, but it's important to recognize that double expressor lymphomas are actually more common than double hit lymphomas. So you'd be more likely to see this than a double hit lymphoma. And usually we do MYC staining, and we have to see more than 40% positivity for MYC and more than 50% staining for cytoplasmic BCL2. So just another sort of examples of large cell lymphomas and a few caveats to mention. So the mediastinal large B-cell lymphomas, whenever we see these, the cells typically crush and are very hard to morphologically evaluate. If you're lucky, you might see some of these just stripped nuclei. And a lot of times these don't survive processing very well and are sort of have poor morphology because they do have this compartmentalizing fibrosis that can make them very tough to get for flow cytometry and to morphologically evaluate. They also can show weak CD30 positivity and may make you think of sort of a Hodgkin lymphoma in some cases. Another thing to consider, particularly in younger kids, and this is usually teenage boys who have large mediastinal masses, would be sort of T-cell lymphoblastic lymphomas. And usually these look like more of an intermediate lymphoid population and usually very aggressive with lots of mitotic figures, and like as you see in that red box. And in addition, a lot of these patients have a high LDH because their tumors are so proliferative and high grade, and that's one of the clues you can look for. Other things are sort of some of the aggressive small B-cell lymphomas, particularly like this case of a mantle cell lymphoma. These can act and almost look like some of these double hit or aggressive B-cell lymphomas. In general, mantle cell lymphomas tend to look kind of boxy and almost form kind of linear arrangements sometimes and don't really have the deep clefts as much as we saw in some of the other lymphomas. But it is always important to include a cyclin D1 if you're thinking of sort of a blastoid or intermediate cell population to rule out a mantle cell lymphoma. Infectious mononucleosis is always something that we think about, particularly in younger patients. And these can have quite prominent sort of intermediate sized immunoblastic cells. They can actually have mitotic figures and can look very, very aggressive. In addition, sometimes these cells can almost look like Reed-Sternberg cells and may actually show some weak CD30 staining. Luckily, they will be CD15 negative, which is in contrast to Hodgkin lymphoma. But infectious mono is something you should think about and consider doing EBV studies on it, and to not overcall malignancy in these scenarios. Another thing that we've seen in sort of kids, particularly in the neck, is sort of cervical thymus tissue. And a lot of times these have two populations of cells, one of these mature lymphocytes, and then another population of cells that almost looks like sort of intermediate type cells. And these can actually show hyperechoic foci on ultrasound and can almost make people think of papillary thyroid carcinoma in the neck. So this is something to think about. And if you were to flow these, they will show basically maturing and immature and maturing T cells like you would see in the normal thymus. And that's one of the helpful features to proving that it is thymic tissue opposed to just a reactive lymph node. Every year, I always feel like there's some germ cell tumor that we think looks like a large cell lymphoma, and so usually when we have a great FNA of a seminoma, you'll see that nice tigroid background as tiger stripes in the background. It can be a little harder, I think, with touch preps. This is a touch prep here. You can see a little granuloma that frequently happens with germ cell tumors. And if you look closely within some of the areas of the touch prep, you get a feel for the tigroid-like background. But a lot of times it just looks like stripped large cells, sometimes with prominent nucleoli, and can really look like an aggressive or large B-cell lymphoma. Another thing I'll just mention is bone lymphomas. So when we see sort of lymphomas in the bone, they can really give off very scant cells on touch prep or FNA. And so a lot of times we're left with working up the actual core biopsy material. And so I will say in these scenarios, if you are thinking of lymphoma, you may want to make sure that your lab is not decaling the specimen, because decal can really make it difficult or impossible to do FISH studies and other molecular studies. And in addition, you may want to do some unstained smears or unstained touch preps that you could use for FISH testing if you needed to. That just confirms the immunos. So just to sort of summarize, when you're looking at lymph nodes, you really need to think about your differential and think about all the studies that you could potentially need for an accurate and specific diagnosis. And I think that as cytologists, we have a really important role to sort of be as the gatekeeper for these lymph nodes to decide what looks like a lymphoproliferative process and what doesn't, in order to sort of allocate these small specimens in the correct manner to really maximize diagnostic yield. So in the last part of my talk, I thought it would be fun to do sort of a virtual cytology game. And so instead of the panic button, I'm hoping we can calmly do this and sort of, I'm going to show you a series of diff-quick stained aspirate smears or touch preps. And the question is simply, would you flow it or not flow it? That's simply the question. So if you're going to press the flow button, you're basically saying that you think lymphoma is in the main differential, and you would want to send for flow cytometry. And if you're going to choose the no flow button, you would say that I really don't think lymphoma is on my main differential. I don't want to send for flow cytometry. I want to preserve material in the cell block or core biopsy. So those are your two options, only A and B. So let's look at the first image. Bone is case number 1. So that's your image. And the question is simply, would you flow it or not? And I'll have Gulise open polling when she's ready.
Okay, Joanne. All right, to flow or not to flow. You know what to do.
Okay, it looks like the majority would not send for flow, but about a third of you are being cautious and saying you would send for flow. So you can show polling results here. So about 2/3 said not to send for flow and 1/3 said send for flow. Correct? Do not send for flow would be the correct interpretation here, because this is actually metastatic malignant melanoma. And some of the things that could lead you to correctly identify that is that you have binucleated cells. And not only are they binucleated, but those nuclei are pushed to the edges of the cell. And DeMay used to call these the bug-eye demons of melanoma, where it does really look like an insect head with these little bug eyes protruding from the head. And if you look closely, it can be hard to look for nuclear inclusions on a diff-quick, but you can sort of appreciate it in that larger cell in the highlighted by the red circle. And in general, they look like sort of plasmacytoid. And when you compare it to nearby red cells, a lot of these cells are quite large. So it looks like a large epithelioid process and favoring melanoma based on the morphology. So the differential of large epithelioid cells, you should always think about sort of epithelial tumors like carcinoma, and then non-epithelial tumors, particularly melanoma and large cell lymphomas and germ cell tumors. But there are a few entities that can give rise to benign bizarre cells. So you don't want to always think that it has to be malignant. And some of the ones that we've seen in our practice in particular that always are difficult are ganglion cells, like you see here, seminal vesicle cells, and radiation or treatment type changes. And so just to show you those a little bit closer, this is actually an FNA from a perirectal mass that was concerning for a lymph node, and it was simply seminal vesicle sampling. And so you can see a lot of times these cells will have pigment and have this like parched earth proteinaceous material in the background, and can have quite enlarged nuclei with quite a lot of atypia. And if you look closely, you may see sperm, which can be helpful. But a lot of times if these patients have a history of malignancy and got radiation therapy, they may actually have low sperm counts. And so you may not actually see the sperm as well. And this is important because it could be inadvertent sampling and that they haven't targeted the area of interest and inadvertently sampled the seminal vesicle, or the seminal vesicle could be giving quite enlarged, making them think of a lymph node. Ganglioneuroma, we've seen these in kids sometimes that were misinterpreted radiologically as a lymph node. And the ganglion cells always surprise me with how quite large they are. And if you look closely, you might see this Nissl substance in the cytoplasm, which can be a clue. And you might even see these neurogenic sort of wavy comma-shaped nuclei within this sort of fibromyxoid stroma compatible with a ganglioneuroma. And usually, as long as you don't see a neuroblastic or small round blue cell component, these tend to be benign. Okay, bonus case number 2. Patient with ill-defined lesion and a history of a fracture. Is it a pathologic fracture? So would you think about lymphoma or not? So I'll have Guliz and Joanne open polling.
All right. So what do we do for these? Do we send it for flow or do we not send it for flow? What do you think? Just a few more seconds and then Joanne, you can close the poll.
It looks like a 2/3, 1/3 split again. So it looks like most people would not send for flow, and about 30% said they would send for flow. So you were correct if you said don't send for flow. So these are actually osteoblasts in a bone biopsy, and usually this is seen in areas with remodeling bone. And you can see here's a cluster of some of these osteoblasts, and when you look at the core biopsy, you'll usually see a lot of these sort of remodeling changes in the bone and these sort of lacunae filled with all these osteoblasts. So osteoblasts have this distinct clearing in the cytoplasm away from the nucleus, and usually the nuclei kind of almost protrude from the cell, which is unlike true plasma cells. And so the main thing you would be thinking about is, could these be plasma cells or a plasmacytic lymphoma or just osteoblasts? So just to compare them side by side, osteoblasts here, it looks like the nucleus is kind of protruding from the cell. The clearing in the cytoplasm is more centrally located and not hugging the nucleus, opposed to plasma cells where sort of the nucleus forms a border of the cell, but is sort of contained within the cell, and the clearing is truly hugging the sort of perinuclear HOF from that prominent Golgi apparatus that plasma cells have. So just a word about plasma cell neoplasms. You really should look closely in the background material of these. We've seen a variety of different things. This is actually a plasma cell neoplasm where a lot of the plasma cells are kind of stripped nuclei. If you look closely, you can see in the center a really nice plasma cell there with intact cytoplasm. But in addition to what you see is this background material that's actually not bone material, but actually amyloid. And you can see here a lot of times you will get this AL or light chain type amyloid intermixed with these plasma cell neoplasms, and so a Congo red can be helpful. Just a word about plasma cell neoplasms in general. If you are concerned about a plasma cell neoplasm and are going to send for flow, you should really tell your flow cytometry lab, because they will permeabilize the cells and actually do cytoplasmic kappa and lambda light chain staining. And plasma cells can be surface Ig negative and have only cytoplasmic immunoglobulin. So in order to really prove a monotypic population by flow, with plasma cells, a lot of times you really do need the cytoplasmic kappa lambda tube, which is the plasma cell tube. So it is helpful if you tell them about that beforehand. Other things that we've seen with lymphomas that have a plasma cell component, this is a malt lymphoma with extensive plasmacytic differentiation. And actually a lot of the sort of excess light chains were sort of crystallized within macrophages in crystal storage histiocytosis. And you can see here macrophages just sort of stuffed with these immunoglobulin sort of rhomboid crystals. And actually on the touch prep, these almost look like fat necrosis with very foamy, sort of xanthomatous looking macrophages, but it's really just stuffed with these immunoglobulin crystals. Okay, bonus case 3, 6-year-old girl with an enlarged neck mass, question lymphoma, would you flow it or not? I'll have Joanne and Gulise open polling.
Right, coming up. All right, would you flow or would you not? How about that? And let's give you a couple more seconds, and then Joanne could close the poll.
Okay, it looks like the overwhelming majority here said they would send for flow. So I agree, you know, in a young kid, a lot of times when there's ever a question of lymphoma and you're not certain whether it is or not, saving some material in RPMI for potential flow could be helpful. I will say in this example, I sort of get a feel that maybe these cells are a bit more cohesive than I would expect for lymphoma, and I really don't see lymphoglandular bodies. In the right-sided figure, you can almost appreciate sort of a tigroid-like background within some of the background, which can be seen with Ewing sarcoma. And so if I look at this, I sort of would favor around blue cell tumor that's not lymphoma. But in kids, when you don't want to make them come back for a repeat procedure, I think it's reasonable to save something in RPMI in case you were wrong. And here you can say for this case, it was CD99 positive and was positive for the EWSR1 break apart, confirming a diagnosis of Ewing sarcoma. And of course, in kids, there's a variety of sort of small round blue cell tumors to think about, and lymphoma is always on that differential. So you want to think about that and really sort of look for entities that may have cohesion and make you think more of maybe a sarcoma than a lymphoma. Okay, bonus case number 4, 71-year-old man with a 10-centimeter retroperitoneal mass, and this was a core with a touch prep. And I'll have Joanne and Gulise open polling.
Right, again, the same thing.
And there's no option to remake the touch prep. So this is kind of crushed and not the greatest one, but it's real life.
Actually, do you want to show it one more time? Just give a little bit more time for people to look at that. Although I guess once the poll is on, it is on. So, okay, flow or not flow?
I thought I would get this. So it looks like it's a 50-50, almost half split on this one. So I think this is a really more morphologically challenging one because it almost looks like cohesive cells. And they do look large and they have a lot of sort of chromatin abnormalities to them, but it's particularly tough. I think in these scenarios, when we're not certain sometimes, it is a good idea to save something in RPMI and then do a prelim immunostain panel of a lymphoid marker, a keratin, and another marker like S100, and then the next day decide if you really want to send it for flow. And so that's sometimes what we do in ambiguous cases, is hold a core or hold some aspirates in RPMI for the next day. And if we don't think it's lymphoma then we'll just process that for an additional block. But if we were concerned about lymphoma, we could send it on for RPMI. So this was a large B-cell lymphoma. And I think sometimes when you don't get an FNA with a case and it's only a core biopsy, sometimes when you make these touch preps, they look very thick. And sometimes that makes it look like the lymphoid cells are particularly cohesive and maybe thinking about more of an epithelial malignancy or sarcoma. And so here you can see this was a CD20 positive large B-cell lymphoma. It was MUM1 positive, confirming a non-germinal center origin. It was actually also CD30 positive and EBER positive. So this is one of those sort of old EBV positive lymphomas that used to be considered of the elderly or, but now just considered sort of EBV positive large B-cell lymphoma. So other sort of large B-cell lymphomas that can almost look like sarcoma or carcinomas. This is an example of anaplastic large cell lymphoma. And when you see these, usually you'll see sort of wreath-like nuclei and these hallmark cells that look boomerang shaped. And that should make you think of sort of anaplastic large cell lymphomas. But I will say, like, there's a whole host of cases where we've been wrong. So this was a case of a soft tissue mass that we thought maybe it could be lymphoma. We saved something in our PMI, and the next day realized it was actually just desmoid type fibromatosis. And the clue here is if you look at some of these cells, they really do look more spindly and have this sort of myofibroblastic cytoplasm kind of coming off in little tails, but particularly tough with a crushed or really artifactually distorted touch prep. Okay, bonus case number 5. I think there's just 2 more. So this is the next one. And the question is flow or not to flow? I would say this is a renal mass. Okay, so it looks like the majority, 3/4 of you said you would not send for flow, which is correct. So this is actually an example of renal cell carcinoma. I was trying to sort of trick you because some of these cells sometimes look very discohesive and are stripped of their cytoplasm. But usually the clue is that you have these nice punched out vacuoles and you don't really have lymphoglandular bodies. In addition, you typically will see this nice sort of arborizing small thin vessels. And in addition, you can see this sort of metachromatic sort of lace-like basement membrane-like material between the cells, which usually is not a feature that we see with lymphoma. So if you said not to flow, you were correct in this case. And this is just another example of renal cell lymphoma, again, showing how they can appear as sort of stripped nuclei, but really you don't see lymphoglandular bodies, and you might see these sort of lymphoid tangles nearby and really look different than your B-cell lymphomas that, although they have scant cytoplasm, usually the lymphomas will have some cells with intact cytoplasm, and again, the lymphoglandular bodies. We've seen a couple of the MIT family translocation-associated renal cell carcinomas that are positive for TFE3. And these in particular, I'm always amazed because on histology, they have abundant sort of cleared eosinophilic cytoplasm. But when we've seen them on aspirates or touch preps, the cytoplasm is really fragile and comes off, and they look like really just stripped nuclei without appreciable cytoplasm. But again, lack of lymphoglandular bodies, and there is this hint of clustering. Okay, final bonus case. Bonus case 6 is a touch prep of retroperitoneal lymph node, and the patient had a history of liver transplant. We see a fair amount of transplant patients in Pittsburgh, and a lot of times they're wondering if there's post-transplant lymphoproliferative disorder and whether they have to change the immunosuppressive regimen. So they were suspecting PTLD in this case. And so my question to you is, would you flow it or not? Okay, so it looks like the majority of you would send for flow. This is one of my more challenging cases, and I was hoping you guys would say that. So 70% said send for flow and 30% said not. So if you look closely, these do look like lymphoid cells, and maybe some of them look more histiocytic up here in the sort of middle to upper part of the field. And what is probably now going to be very conspicuous once I point it out, but can be really hard to notice on site, is all of these negative images in the background from all the cytoplasm that's kind of come off some of the macrophages, and you just have mycobacteria kind of floating around in the background. And so this is an example of atypical mycobacterial infection, and you can see here the core is basically replaced by these foamy macrophages and these foamy granulomatous clusters. And when you do the AFB stain, you can just see that they're loaded with AFB positive organisms. So this is one of those cases that the touch prep looks non-diagnostic almost, very scant in cellularity, and you would keep asking them for more and more cores. But in reality, it's all just an infectious sort of fibrotic foamy process that's really hard to see on the touch prep. Okay, so I'll just end with some concluding comments. Minimally invasive biopsies have really changed the way that many lymphoid lesions are approached. I think any hematopathologist will tell you they would prefer an excisional biopsy or have the whole lymph node out. But I think there's more acceptance on the part of the oncology community and on clinicians that sometimes that's not feasible or necessary. And so a lot of times people will opt for these minimally invasive biopsies. And I will say, in particular, patients after having a primary diagnosis, when they want to look for transformation or whether some of the immunophenotype has changed, we do see a fair amount of those instead of on small biopsies opposed to excisional biopsies. In terms of workflow, I think as cytopathology labs, we have to decide how to process these and handle the small biopsies, whether it's FNA or core, and which bench, whether it's cyto or hempath, gets which part of the specimen. And hopefully I've shown you that these can be diagnostically challenging, but a really good evaluation of the morphology can be really helpful and critical for properly allocating the material for the necessary ancillary studies that can help you make an accurate and specific diagnosis. And with that, I'll be happy to take questions. In a few weeks, I will be moving on to Geisinger and joining the great team there, and I'm really excited about that. So I've included my personal email because I'll be leaving Pittsburgh in a few weeks, and I'd be happy to take any questions.
Excellent. Thank you very much for that fantastic overview of lymph node FNAs. And for the participants, if you haven't taken anything out of this talk, you should remember that you can actually make lymphoma diagnosis on cytology, provided that you have your ancillary studies to back you up and help you out, if you are careful with the morphologic features that Dr. Monaco very nicely pointed out. So I see that there are some questions from the participants, and I'll kind of go over them. And the first one is, do you ever make a diagnosis of lymphoma without ancillary studies? And to add on to that, what do you do when you, is there any adequacy criteria that you use?
So for lymphomas, the lymphomas that we're most likely to diagnose without, let's say, confirmatory flow would be large cell lymphomas that are morphologically clearly malignant. And particularly in the setting of a secondary or just recurrent relapsed setting. Those would be the most likely ones. But usually we have material to do at least sort of a CD20 stain or an LCA to prove that it's not, carcinoma or things like that. So I wouldn't say that we need to have all ancillary studies in all cases, but in order for us to make a lymphoma diagnosis, we usually do like to have some sort of immunophenotype, whether that's by immunostains or by flow. And obviously you want more ancillary studies in the primary diagnostic setting than on relapse or recurrence. Mm-hmm. And then I think for adequacy, so adequacy is tough. I mean, for EBUS specimens and for sort of EUS guided biopsies, we typically like to see 40 lymphocytes per high power field as just like a rough estimate for something that we would say is truly lesional and from, sampling of a lymph node. In general, a lot of the image-guided biopsies from radiology that are targeting lymph nodes, there's not much of an issue. There's usually clearly more than 40 lymphocytes per high-power fields. It's more that the morphology can be kind of challenging on the small side or the large side end of the spectrum. And really your best chance of making the right diagnosis is really having good prepared smears and touch preps.
Sounds good. Now, another participant gives you a scenario that they're in and asks you, how would you deal with this setting? So their lab receives specimens mostly in an outpatient, performed in an outpatient setting without rows, and they don't have any smears, and everything is placed in Cytolite. So they perform exclusively salient cell blocks and don't perform IHC in-house, but they've had another lab help them out with the IHC validation. And they're asking, what is the minimum number of stains do you recommend validating in this type of setting?
Oh, that's tough. I feel like lymphomas are particularly problematic because I feel like there's rarely a case when we're doing less than 10 immunostains on it. So it's hard for me to be for certain. But if you're not doing flow cytometry, like my first question would be if it's an outpatient setting and they're considering lymphoma, could they send you something in RPMI so that you have something that you could send for flow if you needed to, or spin down to an extra block? If you are just confined to immunostains, I would say at a minimum like CD20 and CD3 to prove that they're B or T cells. And then for the B cell markers, usually we'd like to see like BCL2, BCL6, MUM1, CD5, and CD10 to get it at least into sort of a category.
Mm-hmm.
But I can see that would be tough.
It's very tough, yeah. If you don't have the smears and the morphology, yeah, that's tough. That is tough.
I will say, I mean, particularly in some of our smaller hospitals now, Cytology has been particularly helpful from when they want us to eyeball something to see if they should send for flow. And so that's been particularly in our pediatric hospital. So that's one suggestion if you can't be there physically to maybe entertain Cytology.
Definitely good plan. So here's another question, and that's a little bit of a heme path flow cytometry question. How many passes of FNAs are needed for the flow cytometry analysis? I don't know. Do you guys do cell counts?
We don't do cell counts, but I've heard different institutions have, said that that's very helpful. We basically always try to do dedicated passes for the RPMI, the cell block, or the core, the formalin fixed paraffin bedded core biopsy. So there's usually our typical scenario is 4 FNAs, and as long as the first aspirate looks suspicious for a lymphoproliferative disorder and doesn't show carcinoma or granulomas or any other sign of infection, then they'll do 4 FNA passes. 1 is made for smears and 3 are dedicated for the RPMI. And as long as they're going to core it, we would just touch the first core and then get another 2 or 3 cores that would go into formalin only.
Yeah. It used to be that in 1 milliliter of RPMI, they needed like 1 million cells or something like that. I'm not sure if that still stands.
Yeah, I mean, and then I feel like I still go based on turbidity of the specimen. I think some passes yield more than others. And so that's usually a helpful rule of thumb. I always think that like 2 passes kind of maximizes the chance that if one is really bad, hopefully the other one will have it. Yes. So that is sort of a tough issue is the is how much is enough.
That's right. Yeah. So here's another.
But I think the advantage of having on-site evaluation is that you're not making slides on every pass, right? You're allowed to abort slide material and basically allocate more material for the ancillary studies. Whereas, if they were making slides on every pass and the first one was adequate, you're kind of sort of wasting material there.
Right. Which is why rows is so important in the triage.
Yeah, I think it's particularly challenging, like in those rare scenarios of EBUS cases or EUS cases where you're really not going to get an 18 gauge core. And so you're, managing 5 aspirates, and does it go for cell block or flow, and trying to maximize your answers from those aspirates.
Here's another question, and it's a tough one too. How do you approach lymph nodes that have partial involvement by lymphoma? It might be challenging on a smear where you might still have polymorphous appearing population. That's a tough one. It kind of
I know. Partial involvement of a lymph node can give a very polymorphous population that can easily be sort of misinterpreted as just a benign or reactive node. And so that's why I really think clinical and radiological correlation is essential. Like if you think it looks like a reactive node or just scant atypical cells, but it's a 3 or 4 centimeter mass in an elderly patient, you're more likely to submit something for flow to exclude a B cell lymphoma. So I think the clinical is always helpful. If it's like a lymph node that barely enlarged with a fatty hilum and it's not clinically concerning, I think you're more likely to say, okay, it looks like a reactive node, and maybe not flow it.
Another question about your ancillary test, BCL2 and mixed staining in a high-grade lymphoma. If you have these, do you usually follow up with a FISH study?
Sorry, for the MYC and the BCL2, like for double expressor lymphomas?
Double expressor lymphomas, if you have it on the stain, do you follow it up with the FISH study?
We do the FISH study. So the reason is, so double expressor lymphomas have a worse prognosis than just diffuse large B-cell lymphomas, but the prognosis is not as bad as double or triple hit lymphomas. So we do the immunostains for MYC and BCL2, but we also always do the 3 FISH studies for large cell lymphomas as well. And the reason is because the treatment will be different. It sounds like most diffuse large B-cell lymphomas are sort of considered intermediate grade and can respond to R-CHOP. But once you put it into a double expressor or a double hit lymphoma category, they usually get more aggressive chemo like EPOC and other chemo regimens that are almost more like going towards like a Burkitt regimen.
Couple other questions, and we're slowly running out of time, but I'll ask the last couple of questions. The question is on cell blocks. Do you always do cell blocks? How often do you do cell blocks? Do you prefer cell blocks or core needle biopsies?
I'll address that by saying, usually when there's a lymph node or a question of a lymphoid process, they'll start with an FNA. And if we agree that there is no metastatic carcinoma and no infection, and it does look like a lymphoproliferative process, then we'll ask them if they can core it, if it's easy and safe to core. And if they are going to core it, then usually we'll use the core for our immunostains and will not use the aspirates for a cell block. We will simply put all of the aspirates for flow. But if they said that, it's a periaortic lymph node, it's not safe to core, or they can't core it, then in those scenarios, we will divide the aspirates for RPMI and for cell block. So it's kind of a discussion we have on a case-by-case basis to decide if a core is feasible and going to be of use. And then that allows us to figure out how to triage the aspirates.
Mm-hmm. Sounds good. All right. There's a couple more, but what we'll do is we'll refer those questions back to you so that we're not taking up too much time. And I'd like to thank you very much for volunteering and kind of going over all these with us. This was a fabulous session. And I learned a thing or two, too. So, again, thank you very much.
Thank you.
Yes. And for everyone, so stay tuned. Next week, again, same time, we'll go over some salivary gland lesions with Dr. Zubair Baloch. And until then, stay safe.